All right, I'm Jadene Wong, and together with Janice Lowe, we're going to talk to you about primary care for preterm infants and children. So our goal is to help you understand what to do when you get patients that are discharged from the NICU and where to take them from there, what kinds of screenings you need to do, what you need to evaluate. We don't have anything to disclose. So the US preterm birth rate is gradually increasing, and the most recent March of Dimes data says that in 2021 it was 10.5%. In addition, the March of Dimes noted that there are stark disparities, and they commented that in the US, the preterm birth rate among Black women is 52% higher than the rate among all other women. So this is clearly, preterm infants are going to be a part of your practice, and maybe even more so. So Janice and I currently work in specialties. I'm a neonatal hospitalist, and so I work in the intermediate nursery and discharge a lot of the late preterm babies to all of you. And Janice works in the high-risk infant follow-up clinic. But our background is as general pediatricians, just like you. We worked for decades in primary care clinics, in community clinics, FQHC clinics, and so we get it. I was talking with someone at lunch who said that, I have 15 minutes for a patient. I can't possibly do all these things that are recommended. How can I fit everything in? And that's how we felt. We felt that we're in clinic and we wanted one place to go where we could figure out where are all these recommendations, what can we do? We found the recommendations varied by gestational age. They're being updated constantly, and they come from a variety of different organizations. So how do you figure out in one place what to do when that preterm infant is in the exam room and you have 15 minutes? And so what we did is a few years ago, we developed a toolkit, and we tried to get all that practical information there, so it's kind of a one place you can go to get that information and then go in and see the patient. So we're going to share with you some of the areas of the toolkit, and we're actually actively updating the toolkit, so if you do go online after this, know that by December we hope to have the revision online. So you're going to get some advanced information that's not even in the toolkit yet. I'll talk a little bit about growth and nutrition. So everyone is kind of postprandial, so let's put our thinking caps on. So what growth chart is the best one to use if you have a patient that's recently discharged from the NICU? So kind of take a look at the options, think about it in your mind, which you would choose. I'll give you 5 seconds in the interest of time. So if you chose D, the WHO growth chart, you would be correct. Although when Janice and I do this talk, we find that the vast majority of people choose F, because it's whatever's in your EMR, that's the easiest one to access, the easiest one to get to. So the WHO and the CDC growth charts are the ones that you're going to be using the most. WHO is recommended for infants and children up to 2 years of age, and then the CDC growth chart is used from 2 years of age onwards. So let's look at example. Harry's almost 16 months old. He was born at 31 plus 2 weeks gestation, and you see him in clinic, and his weight is 9.5 kilograms. So if you look at the CDC growth chart, he plots out to the 5th percentile, which to some parents who are so focused on weight can be really concerning, because they're at the bottom of that chart. What's going on? But if you look at the WHO growth chart, he plots out in the 18th percentile. And then if you correct his age for his prematurity, he's actually in the 30th percentile. And Janice has shared with me some patients she sees in high-risk infant follow-up clinic, and the parents aren't focused on development because all they're focused on is the weight. The baby's not growing, the baby's too small. So it sometimes helps to show them these growth charts and explain the differences and reassure them that the growth is fine and that we're looking at some of the other areas that are important. However, we do know that preterm infants are at risk for growth failure after discharge. And so your goals as primary care providers are to always prioritize breastfeeding and breast milk. That's always the best. To look to achieve a normal rate of growth for corrected age. And you want to have a proportional gain in weight and length. And then you want to avoid overfeeding. Some of you are familiar with post-discharge formulas, and these are intended for preterm infants. They give more calories, protein, vitamins, minerals such as calcium and phosphorus than a standard formula. And we know that these are the areas that these preterm infants need a little bit more help with sometimes. The post-discharge formulas can help sustain a growth pattern that's already started in the hospital, and we want them to continue. And some studies have shown that the post-discharge formulas improve brain growth. So this table just shows that preterm infants do need some of those protein, calories, calcium, phos, those areas that the post-discharge formulas address. So which infants need post-discharge formula supplementation to breast milk? Not all of your preterm infants will need that. The ones who need catch-up growth, that's important. Also, the very low birth weight infants are at highest risk. We found that the recommendations for supplementation vary. It can vary by geographic area, by institution, and then as NICU nutrition knowledge improves, there's continued evolution. So we don't have one specific set of guidelines or formula for what to do. The approaches to using post-discharge formula, I find most practically to substitute the post-discharge formula for breast milk for 2 to 3 feedings a day. Then another caregiver can do that feeding, and then you don't have to worry about mixing anything with the breast milk. However, sometimes you can fortify the breast milk with the post-discharge formula and then give that for 2 to 3 feedings a day. And then you want to adjust the concentration of the post-discharge formula or the frequency that you give it based on the growth trajectory of the individual patient. We're often asked how long should these babies be on this post-discharge formula. These are suggested guidelines. They're not set in stone. A lot of it, again, is individual patient following. In general, over 1,800 grams birth weight, those babies do not need post-discharge formula. And then as the birth weight goes down, then you would probably give post-discharge formula for longer, and it could be up to a year of age. The key is to really monitor the growth. So you want to see these babies within 72 hours of discharge from the NICU so that you can get a baseline and establish that relationship, and then follow these patients every couple of weeks until you get a stable weight gain. You want to follow them closely while they're on the post-discharge formula to make sure they get adequate weight gain, and then to make sure that their weight gain is not too rapid. And then, as with many things in primary care pediatrics, you want to use your clinical judgment and individualize it based on the patient. So what about iron? A lot of your patients are discharged with supplemental iron. In general, maintenance doses of iron are 2 to 3 milligrams per kilogram per day for at least the first 6 months, and some references will say even up to a year of age. If the patient is anemic, then you want to give therapeutic doses of iron, which are double the maintenance dose. You can consider monitoring labs. There's no one set guideline. We always say look at the NICU discharge summary and see what they recommend because they've been following those patients. And the reason why we treat with iron is because the babies missed out on that last trimester where they would get their iron stores in the womb, as well as those iatrogenic lab draws that the NICU tends to do. And it also has been shown to improve developmental outcomes. So these patients are at risk for feeding difficulties. I won't go into a lot of details, but they can have picky eating, oral motor problems. Patients that have had an NG tube for longer than 2 weeks can have problems with increased feeding difficulties. Also, caregivers, again, worried about feeding and weight, may inappropriately encourage their babies to finish feedings when it might not be necessary. So that could lead to fatigue, choking, emesis. Ultimately, feeding success relies on both the oral motor skills as well as the infant's behavioral state and organization and environment. So it all plays in together. In 2018, the AAP addressed gastroesophageal reflux in preterm infants, and they commented that GE reflux is almost universally present in these patients. It's a normal part of development. It does resolve with time. There can be a risk of feeding resistance, failure to thrive, food aversion. That's not usually very common. And GE reflux in and of itself is not likely to cause esophageal injury because it's not that acidic. And as you know, the medications we used to use to treat are not really recommended anymore. They're not really that efficacious, and they can be dangerous to the patients. Switching gears, let's talk about immunizations and immunoprophylaxis and how those relate to the preterm infants, how they're different. There was a study in Pediatrics that looked at a 7-vaccine series, and they followed these patients for 3 years of age, and they found that as the gestational age went down, these patients were less likely to complete the 7-vaccine series. This could be due to parent or provider decisions not to give vaccines or more frequent illness that these patients can have. So let's talk a little bit about the vaccines that are different in preterm infants. The hepatitis B vaccine is the only one where data clearly shows a lower response in preterm infants. And the Red Book has this great algorithm. You can't read it here, but you can look at your Red Book and it's there. And it helps the hospitals decide when to give the birth dose of hepatitis B based on the HBsAg status and the birth weight of the patient. To summarize, if the birthing person's HBsAg negative, then the babies will get a dose of Hep B within 24 hours if they're greater than 2 kilos. But if they're less than 2 kilos, then the tendency is to hold off until they're at 1 month chronologic age or get the weight gain or at hospital discharge. If the birthing person's HBsAg positive, then regardless of the birth weight, those babies will get the Hep B vaccine and HBIG within 12 hours of birth. And if the HBsAg status is unknown, that's where it's a little bit different. They all get the Hep B vaccine within 12 hours, but if the babies are less than 2 kilos at birth, then they will also get the HBIG within 12 hours. So the bottom line on Hep B is that if it's given at less than 2 kilos and before a month of age, it doesn't count toward the primary series. So you still have to give 3 doses of Hep B vaccine to those patients in your clinic. And remember that HBIG may have been given if the birthing person's status was unknown and the infant was less than 2 kilos. Rotavirus is another vaccine to keep in mind when you see these patients at their first visit. As you know, you can't start this series once they turn 15 weeks chronologic age. And because it's a live vaccine, a lot of NICUs don't give it. Some will give it at discharge, so check with your local NICU and find out what they do. Studies have shown that there have been missed opportunities to give rotavirus vaccine. And so the key is the first time you see them, always think about rotavirus, see if they are eligible, and get them started on that series. So the hot topic is RSV. And there have been a lot of changes. I feel like I've redone these slides several times because every few days something new comes out. So traditionally, you're all familiar with palivizumab. And with the pandemic, things changed a little bit. And so in November 2022, the AAP was putting out these new guidelines because they commented that RSV activity is different in parts of the US. And also, with pandemics, the surges can happen at different times. And so the AAP said that if there's a typical fall-winter RSV season activity, no matter what time of year, then a region may decide to go ahead and give palivizumab. The standard administration is 5 monthly doses. It gives 6 months of protection. And you can give more than that if a region decides that there is an RSV surge. So as you know, for the first year of age, patients under 29 weeks gestation are eligible. If they're less than 32 weeks gestation with an oxygen requirement, they would also be eligible, as well as if they have certain medical conditions. In the second year of age, if they required oxygen for more than 28 days and also needed medical intervention within 6 months of the second RSV season, then they would be eligible to get it. But those are very specific indications. And then in August, we came out with nirsevimab. And the AAP now recommends that nirsevimab can be given to all infants, and they urge care to be equitable. So nirsevimab is a long-acting monoclonal antibody, and it protects against RSV in newborns. The AAP is recommending that it be given to all infants under 8 months of age who were born during or entering their first RSV season. Infants and children who are between 8 and 19 months and at increased risk and entering their second RSV season can also get nirsevimab. So increased risk for nirsevimab is similar to palivizumab, highlighting the fact that the American Indian and Alaska Native children are now a requirement. Before it was a consideration, but now it is a strong recommendation for increased risk. So nirsevimab is given October through March. You can adjust the season based on regional guidance again, and that will depend on local RSV activity. I know in the southeastern states it's already starting to ramp up. Nirsevimab can be given in the first week of life or just before the start of the RSV season. And it can be inpatient or outpatient. I know some hospitals are considering it. It's also weighing financial considerations, listening to different webinars. You'll have to check with your local hospital to find out if they'll be giving it or not. So if the birth hospitalization is prolonged, then you can give nirsevimab just before or after discharge. If nirsevimab was given, you don't have to worry about palivizumab. You're done for the season. If a patient was started on palivizumab, then you can give 1 dose of nirsevimab, and then again, you can call it good and you're done with the season. Because this is the first year and we're not sure about availability and access, they're saying that you should give palivizumab to those patients who qualify if nirsevimab is unavailable. And then exactly a week ago, the ACIP voted and said that they recommend RSV vaccine. So this is the vaccine that already has been recommended for adults over 60 years. But now they're saying that it can be given to pregnant persons who are between 32 and 36 weeks gestation. And this is a recombinant bivalent RSV vaccine. The studies have been shown to protect these infants for up to 6 months of age. There is a seasonal administration, and as much as I looked, I haven't found exact months yet. I think they're still figuring that out, so keep a lookout for updates. Nirsevimab is not indicated for infants if the birthing person received this vaccine unless it was less than 14 days before birth, because it may not have taken effect, or if the birthing person has an immune or antibody response problem. So the general recommendations for immunization is to remember that Hep B vaccine has exceptions to the usual immunization schedule. Don't miss an opportunity to give rotavirus when you see your patients at their first visit. Keep a list year-round of patients who are going to be eligible for RSV prophylaxis so that when the season comes, you'll know who you need to contact. And then be alert for changes in RSV prophylaxis recommendations because of new products or because of atypical seasonal patterns of RSV. And now I'm going to pass the baton to Janice, who'll talk about screening.
Thanks. Okay, now screening, and I'm going to try to run through this a little bit quickly so that we have a few minutes for questions. We're going to start with a case, though, because the case is really important. Marco was born at 30 weeks gestation, weighed 1,400 grams at birth. Assuming he got the appropriate screening in the newborn period, what additional evaluations are recommended by 30 months of age? Developmental screening audiology and ophthalmology, or audiology and ophthalmology alone? So I think most people usually get this one, but this is the key to this talk. Don't forget to screen them for developmental issues, don't forget to screen them for ophthalmologic issues, and don't forget to screen them for hearing issues. That's all you got to take away from my part of the talk. But I'm going to give you a little more background. This article, again, things have been pretty hot off the press this summer. This article just came out in July about neurodevelopmental screening for children, for preterm infants, and pointing out some of the things that occur with much higher frequency in children who were born preterm than those who were born at term. There are things that present early in life, and these tend to be more severe kinds of issues, such as neurodevelopmental impairment, cerebral palsy, intellectual disability, and autism. But it's very easy for us in primary care to think about that 32-week-old, that 34-week-old. You know, if they get to be like 2, 3, 4, they're pretty healthy, and then they get into school, you kind of honestly forget that they were born preterm, right? But there are things that come up later in life, sometimes in the school years, sometimes even later in the school years, in middle school or in high school. But they might have academic underachievement, speech and language issues, attention deficit, learning disabilities, visual motor integration issues, and developmental coordination disorders, as well as other kinds of things. So always be on the lookout and have a very low threshold for referring children who might be having some difficulties in school or in functioning in their social lives. Additional risk factors besides lower gestational age, we know that the lower the gestational age is, the higher the risks are. In addition, children who have had specific insults to their brains during this neonatal period also have a higher incidence of issues. Things like intraventricular hemorrhage, periventricular leukomalacia, or if they had HIE, those cause increased risk. And we know the sicker children also have increased risk. So if they have BPD, ROP, or NEC, those children also are at increased risk for having more developmental impairments. So the other thing is long-term health issues. So these things might not even come to play until, like I said, middle school, high school. But always keep in the back of your mind that children who were born preterm have higher rates of cardiometabolic disease, metabolic syndrome, hypertension, chronic renal issues, and children who were born SGA also share some of these risk factors. Okay. I have to say that when I was in primary care, late preterm children, the ones born 34 to 37 weeks, once they got past the first couple of months, you know, they might be a little slow to feed, or they might be waking up more at night, and parents might be struggling a little more with that. But I have to say, I lumped them with the rest of my kids after they kind of got through those first few months. But what we do know is that children, even if they were born late preterm, so only a few weeks earlier, they have increased incidence of developmental disabilities, school issues, behavioral issues, other disabilities, and death. So really, these are risks that continue through children's lives and adult lives. The developmental screening for children who were born preterm, the recommendations are no different than the recommendations that you see in Bright Futures. So that's important to know. But what you should have is a very low threshold for scheduling additional appointments in between the usual periodicity visits that are usually scheduled. The things you should be doing at all of the visits, which I'm sure you're doing with all your children, is following the milestones carefully. Check for abnormalities of tone and movement. This is more important in the preterm children because they are at higher risk for having these kinds of issues. You should do the usual developmental screening with an evidence-based tool at 9 months, 18 months, and 30 months. I think most people, are using the ASQ. I'm just wondering how many people use ASQ in their offices. Yeah. And PEDS? Do some people use PEDS? Okay. Any other instruments people are using on a regular basis? MCHAT. Okay, for the autism. Yeah, for autism, probably everybody's using, I don't know, is anybody using anything besides MCHAT. I think most of us use MCHAT at 18 to 24 months for autism. Anything else? Okay. Just wanted to make sure I was still up with the times here. I want to go over a few of the findings for cerebral palsy, because cerebral palsy is much, much higher in preterm children. In some studies with the very preterm children, it is 50 times, like 50 times higher than it is in the overall population. And so I just want to go over some of these specific signs. Early rolling. Why do these kids roll early? They're stiff, right? They have extensor tone. And so they roll, it's easier for them to kind of like roll over and the whole body goes. Thumb in the fist after 7 months. Things that you're not going to miss: inability to sit by 9 months, inability to walk by 18 months. You're not going to miss those. Milestones out of order. They're rolling over, early, and they're standing, right? Sometimes they stand because, again, they've got all that extensor tone, their legs are stiff, so they actually can stand not on their own, but stand with support earlier than they can sit. So some of these things are out of order. And then persistent toe walking is another one, or when they're standing, if they're on their toes persistently. Concerning signs on physical exam: hypertonia or hypotonia. Scissoring of the legs, again, that's from adductor tone, and they're crossing their legs. Persistent primitive reflexes, ankylosing, and any kinds of abnormal movements or postures. Anything that's asymmetric, also asymmetric crawling, asymmetric movements of their arms or legs. So always be thinking of asymmetry. This is a picture taken in our own nursery by Dr. A.B., of a child with hypotonia. I don't think any of us are going to miss this as being somewhat out of the usual child. And these illustrations illustrate some of the scissoring and toe walking you can see. So I always made it a practice when I was in primary care to pick up every child so I could feel their tone. And if you're picking up that 4-month-old and their legs are crossing, you need to make a referral right away if it's constantly. If they cross their legs once, okay. But if every time you pick them up, their legs cross, you need to refer those children. And again, when you're putting them down and standing, if they're standing on their toes, if they stand on their toes a little bit and then they flatten out, that's one thing. But if they're persistently standing on their toes, they should have a referral to neurology, physical therapy sooner rather than later. And these are just some of the places that we would refer children with any kind of developmental concerns. I'm sure that you all are aware of early intervention programs in your communities. And then the therapies: physical therapy, occupational therapy, speech and language therapy, and then our colleagues in orthopedics, neurology, and genetics. Moving on to hearing. Hearing occurs in about 1% to 2% of all newborns, and here's that rate, okay? Children admitted to the NICU have a rate that's about 7 times higher than the usual rate, so that's why you have to be especially vigilant to make sure that these children have normal hearing. The AAP guidelines from 2007, so this is way back there. So for a long time, these have been in effect. All children should get either ABR or OAE, and all children should be screened by 1 month of age. So again, need to make sure that none of those children got lost. They might have failed their newborn screen in the hospital. Make sure they get back by 1 month of age for their repeat hearing. If it was failed, they need a full assessment by 3 months of age, and they should get intervention by 6 months of age. What studies have shown is that the children that follow this, they call it 136 guidelines, they have better language development, better outcomes than children who don't get this kind of early intervention. NICU admissions should have ABR screening instead of OAE screening. Some hospitals only do ABR, some hospitals only do OAE as a routine, so it's important to make sure that all the NICU admissions do get ABR. And then children who were admitted, readmissions for high-risk conditions, such as hyperbilirubinemia that required exchange transfusions, and sepsis, those kinds of things need more frequent hearing as well. So all NICU admissions, okay, 2023, this just came out last month. All children that were admitted to the NICU for greater than 5 days should have a repeat hearing screen by 9 months of age. Now that's, I have to say, didn't do that. I didn't do that in primary care. Again, 2023, just be sure you know about these guidelines. Also, close monitoring of their language skills and their middle ear status, and refer sooner rather than later. And then after that 9-month check, then you might consider continuing to screen them, and again, it depends on their risk status. So let's just say they had meningitis, let's just say they had hyperbilirubinemia that had needed exchange transfusion. They're going to be at higher risk than some of the other children that might have been in the NICU for a short time and not had those specific high-risk conditions. And this guidelines tells you, the various kinds of things and recommendations for those hearing tests. The audiologists usually have them right at their fingertips too, so hopefully if you refer them once, they'll say, oh, we want this child to come back again in 3 months, or we want this child to come back in 6 months. Moving on to ophthalmologic screening, retinopathy of prematurity. I think you're all pretty familiar with this. Highest risk for children that were less than 1,500 grams at birth or less than 30 weeks. There are a few children that were older or larger than this that have had unstable clinical courses that might have retinopathy as well. I think I'm going to go through, skip this slide. You can look at your syllabus as needed. Again, just in the interest of time. But I didn't even realize this when I was in primary care before I started doing this work, that children who were born preterm, almost 30% of them can have ophthalmologic refractive errors. And it's much higher rate. So you can see in this study, it's at least 3 to 4 times as much as the children who were born at term. Again, the more preterm you were, the more highly affected. And then strabismus also, really, really high incidence in these children. So that's why it's important to be following their ophthalmologic status. Moving on to, actually, it feels like one was good. Okay. Moving on to psychosocial monitoring. We know that all of the parents of children who were born in the NICU are at higher risk for having psychosocial stresses. We know that there are many kinds of families these days. Most of these studies are looked at traditional mother and father incidence of issues, but what we know is that postpartum depression is much higher than in mothers of preterm infants. We know that paternal perinatal affective disorder is also higher in fathers of preterm infants than children that were born at term. And besides these things being higher, the parents are still taking care of these children. And I know you're seeing them in your office, right? They're going through many sleepless nights. They're not comfortable yet, having their child taken care of by other people. They're exhausted. And as you all know, exhaustion does make you more susceptible to psychosocial difficulties. So just refer early and try to always keep that heightened awareness for the parents of these children. I'm just going to briefly talk about care coordination and transition. Is there anybody here who works in the inpatient setting? Who works in inpatient? Okay, you. Who works in the outpatient setting? Okay, most. And who works mixed? They do both inpatient and outpatient. A few hardy souls doing both. Thank you. Okay, so we're going to talk about where we have our toolkit posted. The California Perinatal Quality Care Collaborative, CPQCC, is a statewide collaborative of California NICUs and high-risk infant follow-up clinics. It's housed at Stanford. And they have a number of toolkits to help with care and quality issues in the NICU. The best practices call for NICUs and well baby nurseries to do as much as possible before they discharge children. I think in California we're especially attuned to this because how about those wildfires, right? You thought you discharged a child from the NICU or from the hospital. You thought they were coming back in 3 days to get their next check, and you thought, they can get their vaccines when they go to their primary care. Well, what happens in between? Fires, right? Whole neighborhoods shut down. we all know COVID shut down the whole country. So we really recommend doing as much as possible before discharge. So if you have control over NICUs or you have any influence on the NICUs in your area, make sure they're updating immunizations and immunoprophylaxis prior to discharge, and that they're making any referrals that are needed, because those can be, moving along even if some disaster befalls or the parent just doesn't make it to the next visit. And this is what Jadene and I have worked very hard on to help those of you who have those 10 minutes to see these kids, right? So pretty much all of the recommendations that we have are listed here. This is a modifiable Word document. And so again, if you have any influence on NICU discharges or you do them yourself, you can take this document, put it into your medical record as a template, and you can change it. So if any of your recommendations are different than what's on here, if you want to add the phone number of your early intervention program or how to make a referral there, if you want to list where you send children for audiology, this can all be incorporated into your discharge summary. I think when we're all in primary care, when you're in the hospital, and what Jadene's job, she's discharging 30-weekers, 32-weekers, 28-weekers all the time. But when you're in primary care, you get one of these kids maybe a year, or maybe it's a couple years, but you don't remember what you're supposed to do with this child, right? So if you have influence over your NICUs, you can ask them to incorporate this. And then for you all who are practicing on the front lines, our toolkits are here, posted on the CPQCC website. It's actually on our last slide is the link to this. This is, in a nutshell, our recommendations for today. So I have a friend who I've worked with, and she says, I keep this in my office, or I keep it bookmarked on my computer, so when that child comes in, it's been 2 years since you saw a kid that was 28 weeks, and you're like, what am I supposed to do? Pull out this sheet. You can't remember when you're supposed to count the hepatitis B or when you're not supposed to count the hepatitis B. Look it up on here. And then this is a periodicity table. I think you're all familiar with that from Bright Futures. If you have that 9-month-old that comes in new to your practice, you haven't seen them before. They were a 30-weeker. And you're like, oh, now what was I supposed to screen and what was I supposed to do? Go down the 9-month column and hopefully you can find all the answers there. So we really tried to construct this, again, having been in your shoes and doing primary care, we really tried to construct this so that it would be easy for you to read and use. If you have any suggestions, we'd love to hear about them. We are updating it, as Jadene said, so there are a few changes since this was put out in 2018, but as of December, it should be all updated. And just thanks to all of the crew that we had that helped us with this, and we thank all of you who are out in the community and in hospitals all over the place taking care of these children. This is the website to obtain the toolkit. Okay.
So we do have a few minutes for questions. People have specific, you guys can.
I have one for Dr. Lowe, I think. You went through the RSV prophylaxis a little quickly.
RSV.
Oh,
RSV prophylaxis.
okay.
So Synagis before this is kind of weak by now. I know it's sort of like generic names.
Right.
They're both monoclonal antibody. Perfortis is long-acting.
Mm-hmm.
Is the same children that should get one or the other, either the Synagis monthly or the Perfortis, or is it? I missed that slide.
Right. So I'm going to use the generic names, right? So the nirsevimab is the new one that's been approved in August, and it's recommended for all infants. There's no high-risk categories, all infants up to 8 months of age. And so that's a big change because all of your patients that are coming through are going to need that. And to check with the hospital to see if they're going to give it before they discharge their newborns. Stanford made the decision that we are going to be vaccinating are patients with nirsevimab before they're discharged. So if any of you are at Stanford affiliated clinics, but if they didn't, then you'll have to do it in your office. And then in terms of palivizumab, so palivizumab is still around, and that is recommended only for the high-risk groups that you've always given it to all along.
Not if they got the Duracell.
But if they got nirsevimab, then they do not need palivizumab. Exactly. Also, because this changes so much, and I've found that both the CDC and the AAP have RSV websites that are active and being updated frequently. And so I think for this year, definitely looking at both of those websites, that'll help give you the updated recommendations. Because I suspect there may still be more changes. Who knows? They're still trying to figure out availability. Cost has also been a big issue as well. So nirsevimab is birth to 8 months, and then for high risk, if it's their second season, then 8 to 19 months. So someone had a question over here, but yes.
I have one about, is there any role to check labs on preterm babies after they've come out? Because when my clinic looked at this a few years ago, we thought, oh, we should be checking some like labs on like growth and calcium and things like that.
Right, so checking labs of these preterm infants after discharge. So I think Janice and I were looking at that when we did the toolkit, and we found that there are no set recommendations. There's different articles that all have different time ranges. And so what we think is the best thing is to look at the discharge summary, because the NICUs, if it was a concern, if the calcium was a concern, if the hemoglobin was a concern, they'll put that in there and they'll say, hey, check this a few weeks after they're discharged. And so that's why if they can use this Word document and put that in the discharge summary, then that'll be in there and you can follow it. So there's no one set guideline. I think we kind of said, well, if you don't have anything, then a rule of thumb could be maybe 6 weeks after discharge to check the hemoglobin, just because these patients are on iron. There's really no indication to check chemistries unless there was something that was going on for that individual patient. Do you have a question?
So is the new RSV prophylaxis that they're hopefully going to give before they discharge, it's my job easier, but is it only during RSV season, those kids that are born during the season?
Right, so for them to, and now let me just go back to that, because I know there's a lot of, this is the hottest new topic, right? So nirsevimab is seasonal. And so October through March is the season for nirsevimab. Although, depending upon where you are in the country, because I know some of you are out of state, you might have different regional guidance. So pay attention to what your local health departments are saying. Yes?
So for those babies with reflux, and you said that pharmacologically there's really no medication that you don't recommend it. So as they suffer through these symptoms, or the parents suffer through their symptoms, what do you recommend?
Right, so in terms of how do we treat reflux and what do we do, since medications aren't recommended? I think that there are reflux precautions that you can sometimes do. For example, you can elevate the head of the bed. We're very cautious about doing that because the problem is the best way to elevate the head of the bed is to have the whole mattress come up. A lot of parents will just lift the mattress and then the head ends up going like this, right? And then when they're sleeping, then that's actually not a safe sleep guideline. So if you elevate the head of the bed, we tell them to put, back in the day there were phone books, they don't exist anymore, but you can put textbooks, if you have them, under the legs of the actual crib, so that the whole crib is aligned at a 30-degree angle. Sometimes that helps. It's not universal. Keeping the babies more upright for about a half hour after a feeding can also sometimes help. Otherwise, it's a little bit like colic, where you're trying to do comforting measures which may or may not work. So that's a little bit of a dissatisfier for parents. But there's not one way to actually just make the problem go away magically. But it is something they should outgrow with time.
I think there's one more question here.
I'm just trying to
Nirsevimab, yes.
So, like, when it first comes available to us, we're gonna have a lot of kids to be catching up that are less than 8 months, and then supposedly, hopefully, birthing hospitals will be giving it, but then they're essentially gonna be giving it year-round, wouldn't they, because the season's gonna be
So,
8 months would qualify?
right, so when do you give nirsevimab, right? And there's going to be a lot of these patients. And so the season they're saying for now is October through March. And so you would want to give it either in the first week of life, and as you said, hopefully the hospitals will pick up some of this burden, or just prior to the start of the season. This is a weird season because October is going to be Sunday. And so, and everyone is still figuring it out. They're figuring out the finances, the VFC portion. AAP is pushing for equitable access. And we don't even know if we're going to have access. So this year is kind of going to be a funky season. I think the idea is to try to catch as many as you can, but like all of you, I'm going to be looking at the news and checking the CDC and the RSV websites. After that, I'm hoping they will have a more coordinated plan, and so next summer they will hopefully put out more reliable guidelines. I know we're out of time. Diane's going to kick me off.
Short question?
If you have a baby without a hospital discharge summary, and you're not sure if they got it or not, do you give an extra, or do you really wait for
So if the hospital discharge summary does not specify what was given, I assume you're talking about nirsevimab. So I have not seen any guidelines about that. I would say that I would try to get that discharge summary, contact the hospital, call the NICU, ask what they do, because as of now I don't have that. I don't want to get in trouble here. Janice and I can stay outside to answer questions if we need to move on. So yeah, is that okay?
All right.
All right. Thank you all.